Good evening, and thank you everyone for coming tonight. We want to welcome you to the second online journal club for the Journal of Hand Surgery European. The aims of these journal clubs are not only to discuss topics of interest, but to come and learn together about the process of publication. And so for each online journal club, we've gotten together hand fellows who will critique the articles, experts who will give their comments, authors who have written the paper, and an editor from the Journal of Hand Surgery who handled the articles. And we hope this will make a very balanced and informative discussion of the papers presented. And of course, we have you, and we'd love for you to all take part in this. So a reminder of what will happen tonight, we will discuss two papers, and we want to encourage you to post questions through the Q&A function to the panel. So allow me to introduce tonight's panel. First of all, Anthony Gough, our first presenter, is a hand fellow from Birmingham. Rudo Madada-Nyakauru is our second presenter, a hand fellow from London. For our expert panel tonight, we're delighted to have with us Carlos Heras-Palou, consultant from Derby. Most of you will know him very well, especially from the current excellent Derby webinar series. We are delighted to have with us Brigitte van der Heijden from the Netherlands. She was president of the Dutch Society for Hand Surgery and currently a member of the FESH Exec Committee. We are honored to have with us Geoff Hooper, who was previous editor-in-chief of the Journal of Hand Surgery European and the current editor with over 20 years of experience. We're very excited to learn from him about the process of publication. And finally, we're delighted that the authors of the two papers, Marieke and Ryckie can join us. So without delay, let me pass the time over to Anthony, who will present our first paper. Thank you, Anthony.
Good evening. I will be presenting a study published in the journal in 2019 from the University of Amsterdam in the Netherlands. A four-dimensional CT study of in vivo scapholunate rotation axes, possible implications for scapholunate ligament reconstruction. Currently, the biomechanical function of the scapholunate interosseous ligament is not completely understood, and the aim of this paper was to identify the rotation axis of the ligament complex, looking to also identify an optimal location for potential fixation. 21 patients were recruited to the trial, with 11 males and 10 females. The mean ages of the sexes were similar. Exclusion criteria were pregnancy, hypermobility, which was tested using Baton score, previous injury or risk disorders, and an inability to consent. Pre-study ethical approval was obtained, and a 64-slice CT scanner was used for 3D and 4D images. Scanning was performed in the prone position with one arm overhead. 3D images involved a static wrist in a neutral position, defined as the dorsum of the hand being aligned with the longitudinal axis of the radius. 4D images were taken using a custom-made motion device with the fingers contained in a hand grip pictured here on the right. The scans were performed during flexion extension and radial ulnar deviation over a 12-second period. The device allowed the wrist to remain within the scanning space and comparison of motion between participants. Image analysis was performed using custom-made software, and left wrists were mirrored to right wrists. 3D scans were made into a polygon model for the scaphoid, lunate, and capitate. Static neutral was defined on the 3D scans as 0 degrees of both flexion extension and radio-ulnar deviation. Wrist movement was defined as motion of capitate relative to the radius. Motion of the scaphoid relative to the lunate defined the relative rotations and translations during flexion extension and radio-ulnar deviation. Mean and 95% confident intervals were calculated for the scaphoid lunate rotation, and translation parameters for every 5 degrees from 50 degrees of extension to 80 degrees of flexion, and from 40 degrees of ulnar deviation to 40 degrees of radial deviation. Scaphoid lunate rotation was calculated to describe the direction and magnitude of the rotation of the scaphoid with respect to the lunate. Rotation axes for flexion and extension were determined for 5 4D timeframes of the wrist approaching extreme extension, flexion, radial and ulnar deviation. One scaphoid was selected as a reference and all other scaphoids were scaled to it in order to compare mean rotation axes of differently shaped scaphoids. Mean flexion and extension axes were calculated and 95 confidence ellipses for every 2 millimeters was determined using MATLAB. 42 scans with flexion extension images were performed. Extension was from -15 degrees to 23 degrees of flexion, giving a total scaphoid motion of 38 degrees. The rotation around the Y and Z axes were less than 2 degrees, and translation in the X, Y, and Z axes were less than 1, less than 3, and less than 3 millimeters. Radio-ulnar deviation only had 41 scans, as data from one participant was missing. Rotation around the X, Y, and Z axes were less than 8 degrees, less than 2 degrees, and less than 3 degrees. The translations in the X, Y, and Z axes were all less than 2 millimeters. Gender had a significant influence on rotation of the Y axis during flexion extension motion, and this was statistically significant. Hand dominance did not affect flexion extension or radio-ulnar deviation. The rotation axis intersected the dorsal ridge of the proximal pole of the scaphoid and the dorsal surface of the lunate. The lunate morphologies were split between type 1s having 24 and type 2s having 18. But this did not have an effect on the scaphoid lunate kinematics. The maximum scaphoid lunate distance was less than 3 millimeters. Significant effect of gender was found around the y-axis. There were small confidence intervals for the flexion extension and the radio-ulnar deviation, which did suggest that the motion patterns are very similar. The rotation axes for both the flexion and the flexion extension and radio-ulnar deviation intersected the dorsal surfaces of the scaphoid and the lunate. And it was felt that the palmar fixation of scaphoid lunate interosseous ligament would be a challenge surgically, increasing the tension and therefore limiting the normal rotation between the lunate and the scaphoid. This was a well-designed study. Software validation demonstrated an error in measuring kinematics of less than 2 degrees and less than 1 millimeter translation. However, these parameters were not used to quote the figures. All the wrists were anatomically normal, and no axial loading was applied to determine any dynamic changes in the study. So the two questions that I have or the one question that I have for the authors are, how tight did they grip the custom device that was made? And did you consider using grip strength as a measure of dynamic changes?
Thank you very much, Anthony. If you can stop sharing the screen. So a 4-dimensional CT study looking at the scaphoid-lunate relationship in healthy volunteers. Excellent paper. So the question from Anthony, I thought Marieke, you might want to answer that. The volunteers grabbed a rod during the scanning, but there was no mention of the force. Do you think the grip strength should be measured? Do you think this may change the results?
Thank you very much for the question and a very good summary. We did not let patients grab the rod with tension. There was near frictionless gliding possible, and we instructed them to hold the rod not that tight. However, we could not measure this in this setup, so that would be an improvement for the next study. But for now, we did not think it affected the results that much because we had the very small confidence intervals and we did not find a lot of changes. And we also practiced with patients beforehand to check if they could really easily slide their wrist. So for this setup, we don't think it made a huge difference, but we can't be sure because we didn't put in the grip strength measurement device.
Great, thanks very much. So I'm just going to ask the expert panel now. Brigitte, we'll go over to you first. What are your thoughts about this paper? And have you got any questions for the author?
Thank you, Wee. I think it's an important study providing information about the in vivo kinematics of the wrist in healthy persons and which can function as a physiological reference for wrists with SL dissociation, for instance. And the strength of this study is that it's based on live, healthy volunteers instead of cadavers and uses 4D CT scans so we can see actual movement of the wrist bones. And the results are very nicely presented. Shall I go on with the two questions?
Yes, please. Yeah.
Actually, Marieke, I have two questions. In the papers, the volunteers were asked to radially and ulnarly deviate to 40 degrees. And I think that's quite difficult, especially to the radial side. And most people are not capable of doing that. So my question is, how did you manage that? And how did you account for the individual differences in the range of motion? That's the first question. The second one is that the 3D LT reconstruction, that's the most popular technique. And I am wondering if this technique probably changes the axis of rotation. What do you think about that? And if it does it disrupt what is normal according to your study? So, and does that matter?
Yeah, thank you very much for the kind words. Starting with the first question, we indeed also thought it was big, but it is due to that we described or we defined wrist motion as motion of the capitate. That's done in a lot of the papers, the 4D papers. So we started with the neutral position of the wrist, and then we measured the position of the capitate. And then probably when the patient moves ulnarly or radially, it rotates further. So it rotates till 40 degrees. So that's how we accounted for this. And actually, if we also interpolated the data for every 5 degrees of motion. So maybe if a person didn't come to 30 degrees or 40 degrees, we didn't add it to the data. So that's answers to the first question, but they didn't. And that's also an interesting thing, I think, to look to in the future. Because indeed, patients don't usually move their wrist 40 degrees radially. So is the motion of the capitate really the one we should use? I think that would be interesting for another type of research. Then for your second question, I do think that the 3LT desis or the technique that would, I think what you get when you have the SL ligament tear, the scaphoid moves into flexion. So with that technique, you will resolve the flexion deformity you have from the scaphoid, and you will, I think, create a rigid fixation to the lunate. And I guess, but we didn't research this, of course, in 4D yet, that you would more so have mid-carpal motion and a limited motion between the scaphoid and lunate. Because what we found is that you have 38 degrees of motion between the scaphoid and lunate. And with this technique, I don't think that is possible. Maybe some degrees of motion, but I don't think you will get 30, for example. But I think it's a very good technique, and a lot of pain is relieved from patients. So we should try to find out what happens in the wrist if we perform that kind of surgery.
So it might be that the rotation axis don't change, but only the arc of rotation will diminish.
Yes, yes.
Okay, thank you.
Thank you.
Excellent, thank you. Carlos, what are your views about this paper?
I think it's a very nice paper and it's very well done. Just to put it in context, Marieke and the authors, they're a Dutch group, and they've done a lot of research. They've applied similar methodology to scaphoid fractures, to scaphoid non-unions. And also Simon Sterkey, who's one of my heroes, has done a lot of research in mother lungs and distal radial malunions, and it's worth digging out those papers if you are interested in these topics, because it goes through the fundamentals very well. So I'm really glad that this paper was chosen, and I would just like to ask Marieke a question, which would be a bit following on from what she was saying. What would the ideal reconstruction for a scapholunate instability look like?
Thank you very much for the kind words. I guess, like from this paper, you would suggest you would need to create if you would have a situation where you cannot restore the ligament, so it's not a fresh SL tear, but it's kind of older. I would guess you would need to get a tendon, for example, the palmaris longus, and reconstruct it on the dorsal side. So you would create, for example, 2 little screws and then in between a tendon, so you would get a possibility to get torsion there. However, all the research that was done already showed that, for example, dorsal fixation of ligaments and everything, the long-term results aren't that good. So I think it's important, and something we're doing currently also is setting up a trial where we're going to look like, okay, we're going to do the 3LT, but we're also going to do only the dorsal fixation. Like, does this really resolve this rotation axis situation? We know how it is normal, but we're not sure if we can achieve that actually in patients again. So that's a follow-up question and a follow-up study. But for now, for the paper, and we suggest only dorsal fixation. Yes.
Thank you for that.
Yeah.
So Brigitte and Carlos, will this paper change your practice? Carlos first.
Well, it does make me think, because there are a few papers coming up with more complicated ligament reconstructions when you reconstruct the dorsal and the palmar parts of the scaphoidal ligament. What's going to happen is that it's going to stiffen it a lot, I think. Yeah. And if you stiffen it, then the scaphoid will not flex. And the scaphoid has got to flex to allow good mid-carpal joint motion.
Agreed. Yeah.
What about Brigitte?
Actually, I'm very happy with the 3LT reconstruction. And the only thing what matters, I think, is where you put or where you make the hole through the scaphoid. And that's this study can help with that, so that the entrance is really at the dorsal ridge of the scaphoid. So I think this is another proof that how you put the hole through the scaphoid, and the entrance should be at the backside of the scaphoid. But I'm very happy with that technique, and I don't see that much loss of flexion. So I stick with it.
Okay, Marieke, any comments on that?
No, I agree with both of them till now. So I think it's an interesting field to do more research, and there's more to be done.
Excellent. So yes, I think what you provided is a very valuable reference set of values which we can use for future studies. I'm going to ask Jeff a couple of questions now. So Jeff, you actually chose this paper as one of your favorite papers of the year. I mean, there's so many papers out there about the scapholunate ligament. What did you see about this paper that made it stand out?
Well, it was a basic science paper. It doesn't have a level of evidence, incidentally, because it's basic science. If you look at the paper, you won't see a level of evidence on it. It's a fundamentally important question. As we've heard from the discussion already, it allows us to discuss the methods whereby the scapholunate interosseous ligament might be constructed. A lot of papers on this topic, people have just gone straight in and done some kind of reconstruction that doesn't have any sort of scientific foundation, if you like. And the other thing that I liked particularly about this paper was the very good figures that allow you to see exactly the points that the authors are making. And it's a very good aid to understanding. So, you know, I really enjoyed it. And I apologize for my audio system here.
So I guess one of the things the audience may want to know are your views on a paper with healthy volunteers. So sometimes we get papers submitted with healthy volunteers. Are there any sort of guidelines that will make it a better paper?
Yeah. First of all, don't use the term subjects, because that kind of smacks of human experimentation. Always use participants, patients if they are patients, and so on. These, of course, were all healthy volunteers. So whatever is involved, we always look very, very carefully to check that the ethical approval has been obtained, and it's you know, an adequate ethical appraisal, that the patients have given their consent, they know exactly what they're doing. And in this particular case, obviously because it's 4D CT scanning, there's a rather higher dose of radiation, which is mentioned in the paper, 0.3 millisieverts. So it's higher than just a single CT scan of the wrist, obviously, but it's still well within safe limits, and it is important that the dose was stated in the paper. So yeah, it's a topic that we regard as very important, and investigate it very carefully with any submission involving patients or volunteers who have had something done to them.
Great. I mean, it's a very, very good paper. The diagrams are very clear. The figures are excellent. It's very well written. Contains a lot of information. So, but is there any way you can improve on this paper? Is there a way you would suggest to the authors to make this paper better? There's always room for improvement, Jeff, isn't it?
Yeah, but we've accepted and published it. We've gone through all that with you. There's never, in my experience, a paper that's accepted as a straight submission. It always has to go back. There are always some queries that come up, either because of the peer review process or simply reading it through, and aspects of clarity and understanding from the point of view of the reader. And that's what I have to do as an editor, put myself in the position of a reader and say, can I understand this? And this particular paper was fine. There were just obviously a few queries that needed clearing up and clarifying and so on. But as you can see, the end product is a very comprehensible and interesting and readable paper. That's at the end of the editorial and review and editorial process.
Thank you very much.
That's what we like to see as editors, is something published. We're not in the job of throwing things out, but what we want to see is high quality material published as well. And this certainly is.
Thank you. Marieke, having taken all the comments tonight into consideration, if you're going to do this study over again, are there any changes you may make?
Yes, I would add the goniometer. So we a grip strength measurement device. So we would know if there would be any grip strength. So we would have all that discussion, and we could also do some trials with that. So one with the grip and one without. That would be very interesting. So I actually already put it back to the lab to ask if they could implement this in the device.
Excellent. So we look forward to that paper. Excellent. Thank you very much. I think we have one question coming in. So yes, a question from Sue. I assume the investigators are going to repeat the study with patients with scapholunate dissociation.
Yes.
You will do a 4D CT study on that.
Yes,
on
we
actual
would.
patients.
Yeah, now the first one we're starting up is the actual ones that we already did surgery on. So we wanted to check the surgical results. So that's what we're doing right now. And we need to set up with a smaller local hospital to get the acute SL ones. In the Dutch system, it's a bit difficult sometimes in the big hospital to come by a good numbers of them.
Great, fantastic, well done. Thank you. I think if there are no more questions, I will move on to the second paper. Thank you very much, Marieke. Thank you. Okay, so our presenter for the second paper is Rudo Madada-Nyakauru from a Hen fellow from London, and she's going to come and present the second paper about infection, a very relevant topic to all of us. Thank you, Rudo.
Thank you. Good evening. I'm presenting a paper by James Davies et al. Entitled Time to Surgery for Opened Hand Injuries and the Risk of Surgical Site Infection, a prospective multi-center cohort study. The problem identified was surgical site infection after open hand injury within 28 days. And the primary outcome was the impact of time to operation on the incidence of surgical site infection. This was a prospective multi-center cohort study, making this evidence level 2. Surgical site infection after surgery for trauma occurs in up to a third of operations based on the literature. A recent systematic review showed no association between time from injury to surgery and the development of an infection. However, there have been limitations identified in previous papers, including small sample size, confounders not being considered, and dichotomization of time. This, as well as other arbitrary time thresholds that are set, can bring about inaccuracies with the analysis. 983 consecutive patients from 2 tertiary centres in UK were followed over a year. Demographics were collected, including smoking status and comorbidities such as presence of diabetes. Mechanism and pattern of injury was also documented. With regards to preoperative management, the provision of preoperative antibiotics, as well as types of skin preparation, and also all the intraoperative findings were also recorded. Inclusion was adults over 16 with a traumatic from the wrist crease going distally that underwent surgery. Exclusion was those with a pre-existing infection, burns, distal ischemia, and any kind of amputation that required revascularization or replant. Initial review was between day 2 to 10 post-operatively and was carried out by specialist care nurses. The patients were then followed up as the identification of this infection was primarily by foundation and core doctors, but where a patient was seen by several doctors, the grade of the most senior doctor was recorded. The results show that time from injury to assessment had a median of about 3.5 hours, and that most of the patients had their surgery within 1 day, and that the longest wait was up to about 4 days. 95% of the patients had preoperative antibiotics, and only 4% of the patients in total developed a surgical site infection. Management for infection was mainly oral antibiotics, and coamoxiclav was the most common antibiotic used. But a small number of patients required admission and intravenous antibiotics, and a few also then went on to have surgery. The results show that between the 2 groups, there was no significant difference in length of time from injury to surgery with regards to developing a surgical site infection. Here you can see the group that did have a surgical site infection, and here the group that didn't have a surgical site infection, and there was no statistical significance between the medians. To assess for confounders, multivariate analysis was done. And this showed that the length of time from injury to surgery did not affect the risk of developing a surgical site infection. However, skin loss more than doubled the risk of developing a surgical site infection, and this was statistically significant. Skin loss therefore appeared to be an independent factor in the development of an infection. Taking into account some of the other confounders, such as smoking status, being a diabetic, mechanism of injury, and multiple injured digits, none of these appear to affect the risk of developing an infection. To assess the confounders in more detail, marginal effects plots were used. This one looks at patients with diabetes, as this is a patient group that we particularly worry about with regards to the development of an infection. The diabetic group is the red line, and those without diabetes are in blue. You can see that at the start, there's very little difference between the two lines, and the lines then go on to converge. This means that the provision of preoperative antibiotics did not affect the risk of developing a surgical site infection in those with diabetes and those without diabetes. And this colored area here is the 95% confidence interval. Then looking at mechanism of injury, sharp laceration, crush injury, and bite. And again, you can see there's a very minimal difference between these at the start, at the starting point. And then as time goes on, the lines go on to converge. Again, this shows that the provision of preoperative antibiotics did not affect the risk of developing a surgical site infection. Looking then at skin loss, those with skin loss are the red line, and those without skin loss are the blue line. And the difference between these two lines is maintained. And this means that skin loss increases the risk of developing a surgical site infection. You'll also note that the colored areas here are overlapping, and this is the confidence interval for the provision of antibiotics. So this suggests that the provision of preoperative antibiotics did not affect the risk of developing a surgical site infection in patients with skin loss. So in summary, infection in surgically managed open hand injuries was low, as is consistent with the literature, and delays of up to 4 days did not appear to affect the risk of surgical site infection. This level of 4 days was identified as this was the longest wait that patients had within this study. So this serves to reassure both the surgeons as well as the patients that where there is a delay of this time period, it's unlikely to affect their risk of developing a surgical site infection. Incidental findings were that there was no apparent benefit from preoperative antibiotics, and that there was no higher risk of surgical site infection to the diabetic patients. There was also no higher risk of surgical site infection to those with crush injuries or bites. It's important to note, however, that 95% of the patients in this study did actually receive preoperative antibiotics, and that the infection risk was low. So assessment at this level may be underpowered. With regards to diabetics, there was only a small number of diabetic patients in this study, and so it's difficult to generalize this information for all diabetics. We also know that crush injuries or bites are significant injuries, and so caution would be advised with regards to reviewing possible practice when managing such patients. The only independent factor for surgical site infection was skin loss. The authors acknowledge that whilst these additional findings were interesting and insightful, that further studies would be required to gain more information specifically about these areas. So the question that I have to the author is, how was skin loss actually assessed, and what degree of skin loss was considered to be relevant for this study?
Thank you very much, Rudo. So yes, a question has just come in, and I think it's the same question as you, Rudo, and I think it's a question that intrigued all of us. What size of skin loss did result in the increased infection rate? How do you measure skin loss, and what are your guidelines for that? Ryckie, please.
Thank you. Thanks, Wee, and thanks, Rudo, for a great presentation and a very important question. That's a really difficult question to answer, actually, and I think it's only right and proper to fess up and say that wasn't what the study was designed to interrogate. And right from the get-go, that could be a chance finding. It could be a statistical quirk, an error, an idiosyncrasy of the data set. It may not be real. And so we definitely fell foul of weaknesses we pulled out of other papers by binarizing what is actually a very delicate topic, isn't it? Skin loss, where is it? Does it overlie an important structure? How big is the defect? What do you need to do to reconstruct it? We didn't do that particularly well. And in future iterations of this sort of work, we will definitely build upon that and say, for example, measure skin loss by area, or perhaps what was required to reconstruct it. So I would throw caution to anyone reading too much into that. Once again, that could be a chance finding, and it is difficult to say how much skin loss is an important amount, etc. That will be the subject of future work.
Sorry, so in your paper, Ryckie, skin loss refers to skin a wound that needed reconstruction or cannot be closed, or you just want to be quite clear about this?
All of the above, yes. Unfortunately, that is a weakness in the methodology, that it could have been any form of skin loss as history given by the patient or assessment by the doctor. And that could obviously have been closed primarily, or it could have been reconstructed, but we failed to collect data on reconstruction or area of the defect, which would have been much more useful in hindsight.
Great, thank you. Right, I'm just going to ask Carlos to comment first. Carlos, what are your thoughts about this paper?
I think it's a very good paper. I like it for two reasons. The first one is that it challenges dogma, which is what research should be doing. I was brought up on the idea that if somebody comes with a laceration, you should wash it and suture it within 6 hours, ideally. And it turns out that probably that's not a crucial factor. The other reason I like it is because it resonates with me. You know, having worked all my career in a publicly funded hospital, this study was done in Leeds and Wakefield, which are two big national health hospitals, very busy, where you have to compete for theatre time, operating theatre time. You would have to try to work very hard to get your patients done as soon as you can. And often you cannot get them done on the day or the next day. And that worries us. And at least we can now reassure the patients with some evidence that we're not going to do your operation today, but we'll do it tomorrow, and that's not going to increase the risk of infection significantly. I think that's a good contribution.
So, Carlos, will you be happy to let patients wait for 4 days and be very comfortable with that?
No, there are two reasons for that. One is that this is not a good quality service, having people with an open wound waiting. Right? I think it means that if somebody comes with a wound and you don't do it that day, you do it the next day, it's not negligent, but that doesn't mean that it doesn't matter or it's a good service. And the other thing that, and I was going to ask Ryckie that, it seems to indicate that the conclusion that you can leave them for 4 days and that doesn't increase the risk of infection, but actually the average wait for the patients from coming to hospital to surgery was about 20 hours. This is like doing them the next day. It's not like doing them on Saturday. And I think that's different. So I think the message is that waiting doesn't increase the risk of infection, but it's not that you can just leave it and we'll do it whenever it's convenient to everybody.
Great. I'm gonna ask Brigitte now, and maybe come back to you, Carlos. Brigitte, what do you think about this paper? And have you got any questions to ask Ryckie? You're muted, Brigitte.
I totally agree with Carlos that it's a very nice paper with important relevance for daily clinical practice, and it has a big sample, a good study design, and a good use of statistics. But of course, I have questions, and the first actually was the same about the size of the So that's already answered. The second one is regarding the use of the preoperative antibiotics, because only 5% of the patients did not receive the antibiotics. So I doubt if it's possible to draw any conclusions about the use of antibiotics and the risk for infection. So you reported a very low infection risk, about 1.8, but do you think that the antibiotics still play an important role? And should you have mentioned that in the abstract as an important point if we want the patients to wait? That's actually the most important question.
Ryckie, please.
Thank you, Brigitte. That's a really important question, especially in the area of antimicrobial stewardship, all the problems of antimicrobial resistance that are growing. I think to answer it, I probably have to refer to some of Murphy's work in 2016, in Garden and Abby Jane and colleagues and so on. They've meta-analyzed this topic already. Simple hand injuries, antibiotics don't reduce the risk of infection for injuries that are managed surgically. We had a little bit of data to that. They didn't include open fractures or bites or crutch injuries and things like that. We did. Even still, in practice, a vast number of patients are receiving antibiotics for relatively minor injuries that are going to be treated surgically in the end. And I think it's probably not really clear whether or not we should be doing that. We should be giving them antibiotics or not, if they're definitely going to have surgery. And I think probably for those very, very clean injuries, there's really quite good evidence already that we probably don't need to be giving them antibiotics. But for the other things like bites and crushes and more complicated injuries, there's definitely a void that should be filled by a large trial, for example, on this very topic, very, very important topic. But again, with our paper, that was a secondary outcome, a chance finding, if you like. It may be erroneous, it may be a glimpse at the truth, but it definitely needs to be looked at a little bit further. Does that answer the question?
Yes, thank you.
So Brigitte, Carlos mentioned that he works in a public funded hospital and he has sometimes problems getting patients in the theater. Do you have that problem in the Netherlands?
Yes, of course, we also have the capacity problems, and that's the reason why they have a system for categories. So you have 4 categories and you have to decide in which category your patients fill in. And the worst one is category D, because then you can wait for 24 hours. But when you are in D, you can be there for more than a few days. So that's the problem, because it can be postponed repeatedly. And considering that, I agree again with Carlos. It's of course not only the infection risk, it's also the recovery of the function. So that's not the aim of this article, of course, and it's nice to know that we have some time before the infection will occur, but we also want to offer service to our patients and want to have the best recovery of function, of course, and maybe then waiting time is not that nice. So that's an issue, of course.
Thank you. There's quite a few questions coming in, and quite a few of this relates to skin loss. Ryckie, I'm gonna start off with some of this. Interesting question. Did you study the difference between wounds on the palmar aspect or the dorsal aspect?
I wish we did, but we did not.
Okay. Did you mention the absence or presence of fractures as a? Yes,
there's numerous categories within that are the data is tabulated in a fracture, a tendon injury, a nerve injury, vascular injury, all these other kind of things.
Yeah. Okay. So I think another question from Jonathan Hobby, I think relates to the whole sort of, I mean, I guess the philosophy behind this study. What was your main purpose? Is this part of a larger body of work to really address the various elements? Antibiotics, washout, temporary closure, fractures, skin loss. Is it leading to a bigger study to get more data?
In part, yes, is the truth. I mean, this is the bread and butter of hand surgery, isn't it? Dealing with open trauma. And there are a great many aspects of our management that are not underpinned by really robust research. And this is just a very small part of that large picture. And so a number of other topics will be addressed in the the years to come, like skin prep and sutures and other bits and bobs. And so hopefully this just provides a little bit of data that may provide some comfort that we don't need to get up in the middle of the night to operate on a small open hand injury. We can wait till the next day or perhaps 2 days, something like that.
Okay. Tim Hans asked, have you any information regarding the benefit of post-stop antibiotics?
No, I think would be the honest and right answer to that.
Is that something that you might be looking at in the future? There's quite a few ideas here coming through, Ryckie, which is great.
It's a treasure trove of research design ideas here.
Yeah, so yeah, keep all that in mind. I'm going to ask Jeff a couple of questions and maybe come back to you again, okay? So Jeff, thank you very much. This is another paper that you handled. And I'm sure you agree, a very important message that can potentially change practice. What do you like about this paper?
Well, what I liked about it was that it dealt with an important topic. And as Ryckie said, it's an everyday practical topic, bread and butter of hand surgery. And it sheds some light on that very important question as to how urgent is it to deal with skin problem in the hand. So yes, it's basic everyday hand surgery with a large series, and the authors and people involved in the study had attempted to eliminate quite a lot of the variables or design faults that have affected previous studies on the same topic. So yeah.
That's great. I think quite a few of the questions related to the statistics, Jeff. So, what was your experience of reviewing the statistics in this paper for Ryckie and the other authors?
Well, the difficulty was when the paper first came across my desk was that it was rather difficult to follow the highly complex, relatively complex statistical methods that had been used to deal with the data. So my job was to liaise with the authors to get the explanation of the statistics a little clearer for the average reader. And I mean, obviously the average reader is going to be very interested in the topic of this paper, so they want to understand as best they can how the authors have set about it. And I think at the end of the day, it was the statistical methods, sophisticated though they were much clearer to be understood. We do have statistical advisors that work with the editorial board to help with papers, and in this particular case, I don't think a statistical advisor was required because the methods at the end of the day were comprehensible and honest. Of course, sometimes we get papers, it has to be said, where it looks as if the data have been heavily fudged in some way, and they would certainly, we asked then for the actual data set to be sent in to the journal to be looked at by the statistical advisor. And often there's some very interesting feedback from the statistical advisor dealing with the paper. So we do have that extra method when things are a little bit problematical with numerical data.
Thanks, Jeff. I mean, that was actually my next question, which I think you've answered very well. What advice would you give to authors or potential authors who may have certain questions about statistics? And I certainly found the statistical advisors very helpful in providing advice in this matter. My next question has to do with the use of antibiotics in diabetes. I think that's sort of mentioned once or twice. So the authors concluded that antibiotics did not make a difference, and they presented the graph, and they did mention the numbers were small. I think 3 out of 47 had an infection, and they did mention that in the limitations. So my question really is, should the author or should authors mention findings with weaker statistics and then discuss that in limitations? Or should they not even mention it at all?
Well, it varies from topic to topic, obviously, and from paper to paper. But in a way, you could have said that this paper could have been made much simpler if they just stuck to the primary aim and left everything else to one side. I'm just putting that as a suggestion, so that time to operation, what effect does that have? And that's kind of open and shut. As you mentioned, it gets a little more diffuse when we're looking at these things with small numbers of patients in the first place, small numbers of infections, progressively weaker evidence, and so on. Yeah, I mean, I think it was good to have that in, and the limitations of those data have been acknowledged clearly, so the readers can make up their own minds about the strength of that particular aspect of the evidence.
Thanks very much, Jeff. So all authors take note that that's quite an important message about publications. There's still quite a few questions coming in, and we're delighted about that. There's a few questions to you, Ryckie, about washouts. So does pre-op washout or washout of the wound at the initial assessment, maybe with local anesthetic or whatever, did it make a difference? Would you advocate that? If you're going to have a delay to surgery, should you advocate washout?
I suppose that's quite a good and important question. And I guess none of us really expect delays or can forecast delays. And is there much harm done by toilet washing out in the ED or anywhere else? Probably not. Is it very expensive? Not really. And there's already Cochrane work out there to show you can do it with tap water. It doesn't need to be anything sterile. So I'd say probably yes, you could do it, and there's no reason not to. So whether it is a component of the overall infection reduction package or not, I think it's really quite difficult to unpick. And I don't think it'd be ethical to do a particular study looking at that. So I really don't know the answer to that, but I don't see a good reason not to do it.
Okay. So Ryckie, we sort of coming to the end of this. So a couple of things for you to take back from here. I think people are very interested in this study and in you doing more work on this. What are the particular areas you might be looking at taking this forward? You can't just stop there, Ryckie. You gotta take it forward.
Well, with Geoffrey's help, actually, and I owe a huge debt of thanks to him. Actually, he was tremendous in shaping this paper into something that's digestible, and that process was also very helpful for me to know what we as a team could have done better the next time around. And so there are definitely things that I would measure differently because it's better and easier to model it, or it would provide answers to questions people are probably going to ask a year or two down the line, like you've all asked tonight. I would also include people with bilateral injuries and multiple injuries, because the modeling for that now is achievable, and that would make the results that much more generalizable to our practice. And I do it bigger because bigger numbers are always better to model. And we have the infrastructure now through the RSTN and BSSH to achieve that. And there is interest in the topic and manpower on the ground. So yeah, all of those three things.
Fantastic, thank you. Okay, I think we've come to the end of this journal club. I hope that was useful, not just in terms of the topics, but also in terms of the process of publications. I think we've chose two very different papers tonight deliberately. The first with the use of some may consider a sort of more of a controversial investigation, 4D CT on healthy volunteers, and perhaps the ethical process involved in that. So that is a good paper to read if you are considering a similar study. And obviously the presentation of results in that first paper is really superb in terms of how they thought about everything and the presentation of their data. The second paper, we chose that because we know that is something very close to all of our hearts. That's a paper that can potentially change practice, and And we really look forward to the team taking it forward. I think, Ryckie, before you go, just have a look at the chat group. I think there's lots of suggestions that's come in for you to take on board. I'd like to thank all of the panel for taking part, especially the authors for being so brave to attend. I hope you found it beneficial and rewarding. I want to thank the amazing team behind these journal clubs, and we hope you've enjoyed this session and learned something about the process of publication. Just a reminder that we will be holding this journal club every 2 months. So the next one will be on the 27th of January. We will be inviting our editor-in-chief, Professor Jimbo Tang, to attend as the handling editor. So till then, take care and stay safe, everybody.